Hello students, in today's session we'll be discussing briefly about cardiovascular symptoms, and the symptom that we are going to discuss in today's session is chest discomfort. So when we look into this chest discomfort, our main approach is to make sure that we are not dealing with any life-threatening cause of chest discomfort. The non-life-threatening complications can be managed slowly, but we should take a good history, we should do a good examination to make sure we identify these life-threatening causes of chest pain. So that's what we are going to discuss in this session today. Patients can come to the emergency department or your outpatient department with chest pain. So the important causes which are important for us, which are life-threatening, could be a cardiac related, that's a myocardial ischemia, sometimes a pericarditis, acute pneumothorax, acute pulmonary embolism, aortic dissection, sometimes esophageal rupture. So the important life-threatening conditions are there. So our aim is to identify these life-threatening conditions, differentiate from them based on clinical examination, history, as well as relevant investigations which you have to do it urgently, and then proceed to management. So variety of causes are there. So the cardiac causes being myocardial ischemia and pericarditis. So the myocardial ischemia, you could have the classical angina, which is precipitated the precordial chest pain, retrosternal tightness, squeezing, burning. Sometimes they would have it, and they would come with coming on exertion, relieving on rest or nitrates, usually retrosternal, and it radiates to the jaw, arms, as well as the epigastrium. Usual features associated with that would be a cardiac failure feature. So you could have an S3, you could have the pulmonary edema features, an acute MR, etc. could be there. The second cardiac cause is a pericarditis, where the patient complains of a retrosternal chest pain, which is pleuritic, sharp pain, and when you examine, you might find that there is a pleural rub which may be relieved on sitting up and leaning forwards. Could be an acute aortic dissection, that's an important cause, sudden onset, unrelenting pain, tearing, ripping type, central, and you might find hypertension, pulses may be feeble in the lower disease, etc. Pulmonary embolism, a particular patient, sudden onset, sharp pleuritic pain, hypotension, hypoxia, tachycardia, and you might find that the patient is dyspneic. Pulmonary hypertension sometimes can present with the chest pain, which could be exertional. So patient complains of a pressure there, and you might find features of pulmonary P2 loud and RV failure, etc. Pulmonary causes, you could have a pleuritis, pneumonia, or a pneumothorax. So usually pleuritic pains are sharp, unilateral, lateralized, and they could have other features. The patients can have fever, crepitations. With the pleural effusion, they may have dyspnea. Also, they may have diminished breath sounds, and in pneumothorax, they may have hyperresonant percussion note also. The non-cardiopulmonary causes, the GI causes, the gastroesophageal reflux disease. Usually, the patients with after meals, they have this pain, burning sensation. Associated with the reflux usually occurs after feeds, postprandial, and it is relieved usually with the PPIs or antacids. Same with esophageal spasms, which gets relieved after maybe possibly drinking some analgesics, etc. And you could have peptic ulcer disease, and sometimes gallbladder disease also can manifest. The neuromuscular, you could have costochondritis, usually on the in the anterior end of the costochondral junctions, they'll have localized pain. More often the upper costochondral junctions are involved, you may have tenderness, warmth there. The cervical disc disease, sometimes you could have a radicular pain which comes onto the chest, and they would have movement when there is neck movement. They may have some neurological features that could be seen there. trauma or strain that could produce the pain either due to a fracture or a musculoskeletal problem there. Sometimes herpes zoster, you might find vesicular lesions in the dermatome. Sometimes you could have psychogenic causes, which could be emotional, psychiatric conditions, variable manifestations, and you will definitely have a stressor that you could see. So these are some of the broad disorders which can manifest with a chest pain as a manifestation. So we will have to keep it in mind when we look at the chest pain. So our main concern is about angina. Now this patient has angina. So angina is because of a mismatch between the supply and the demand. So when the blood supply is decreased, either due to any causes like an obstruction to the lumen, or the demand is increased when possibly there is a physiological need increase, or maybe a muscle hypertrophy has happened. So this imbalance between supply and demand results in angina. So very importantly, this comes usually on exertion, after a cold weather, usually after a meal, and it is relieved on rest or by taking nitrate. So that's the very characteristic feature of angina. Majority of the patients with angina do have an ischemic heart disease as an important risk factor, but you could get angina even with chamber enlargement, LV hypertrophy, as it occurs with aortic stenosis or HOCM. Sometimes you could get angina due to pulmonary hypertension also, where there is an increase in the hypertrophy that could be seen there. Again, the characteristic feature of angina, you could have unstable angina, which is a new onset angina, changing character of angina, and the angina which is persistent. If the angina persists for more than 20-25 minutes, that is when we consider this patient to be having a myocardial infarction, which comes to acute coronary syndrome as a classification there. It is important for us to note that angina radiates, so it can radiate to the left jaw, sometimes to the right or left shoulder and the arm also. So very characteristic feature that you would get there, that is very characteristic of angina. So when a patient comes with angina, we have to make sure that this patient is evaluated. The simple ECG has to be done. Look for any changes, ST elevations, ST depressions, T wave inversions in the vascular leads that is there. If the ECG is normal, we may have to do the cardiac enzymes also. If both are normal, then possibly we will have to repeat it again if the symptoms are classically that is seen. So it's very important that we diagnose unstable angina, ST elevation MI and the non-ST elevation MI based on when patient comes with angina that you would see there. Our main concern whenever a patient has angina is to identify the acuteness of the situation and refer it to further management. So reperfusion therapy has to be done either by thrombolysis or PCI. So we have to make sure we diagnose MI very characteristically early. Non-atherosclerotic processes like you could have congenital abnormalities of the coronary vessels, myocardial bridging, coronary arteritis, radiation-induced coronary disease. All these can cause non-ischemic causes of coronary artery disease where the luminal narrowing could happen. Sometimes you could get angina, as I said, with hypertension, with hypertrophy of the ventricle, hypertrophy cardiomyopathy, restrictive cardiomyopathy, you could get it, and sometimes with severe anemia also you can have angina as a feature that you could see there. Important is the characteristic. Many of the patient would come with something called as a Levine sign, as if the fist held onto the chest. That's the pain, crushing pain they say. But sometimes the patient may not complain of pain also. Heberden was the initial person who described angina. He described it as a strangling and anxiety feature. So it's a sense of doom that is coming there. Some patients, especially with the autonomic dysfunction like diabetic patient, can have angina without chest pain. So they may not have chest pain at all and the angina might be present, or ischemic heart disease, what we call it as a silent MI that could be seen. Very importantly, stable angina, unstable angina and MI. So stable angina is where it gradually reaches, slowly increases, reaches the maximum, and then after rest or nitroglycerin it decreases and it comes only later on exertion. Chest discomfort which MI usually lasts for more than 20 to 30 minutes that you could see there. Now the cardiac chest pain is basically a neural ischemic cardiac chest pain. What is the pathway for that is not clearly understood. There is various local chemosensitive phenomena, the mechanosympathetic phenomena that's there, where there's a release of adenosine, bradykinin, substance P, all these are released and they would activate. And the primary nerve that is getting stimulated or activated is the vagus. So it goes through the thoracic sympathetic ganglion, and then there it goes to the thoracic roots. It's going to the thalamus, and from there it comes back, and you would get these through the vagus nerve. You get these manifestations that you would see there. So you would have other features that are associated with the angina. The patient can have perspiration, they can have a sense of nausea and vomiting that you would come there. And again, remember, the radiation is all because of the vagal efferents can get stimulated. So whichever area the vagus gets supplied, you may have the radiation of pain that you could see there. The other important cardiac cause that you see is the pericarditis. Usually viral pericarditis, Coxsackie, echo viruses are the common causes. You could get bacterial, you could get other causes also, non-infectious causes also. So the visceral surface and the parietal surface of the pericardium are insensitive to pain there. Small part of the parietal would be sensitive possibly. So the rubbing of that is usually associated with pericardial inflammation that you see there. So here it is very pleuritic, localized, increases on coughing, increases on movement, and usually it is retrosternal in space there. And again important, pleuritic chest pain usually resolves once the pleural effusion sets in, but a pericardial chest pain would always remain there. Again, this pericarditis may not be infectious, it could be inflammatory or other causes that could be seen there. Again, we require to do an echocardiography as well as an echo ECG, which will help us to. Again, we'll have to do an ECG, which will show ST elevations, all the leads, camel hump, ST elevations, PR segment depressions might be seen. Echocardiography will confirm. It's important for us to find out the cause, and also, patients would be required to be treated with analgesics, sometimes steroids, sometimes colchicine, and monitored. Because this pericarditis, the fluid can increase and the patients can go into constriction physiology also. Other causes of chest discomfort, as we said, mitral valve prolapse can manifest with the chest discomfort, hypertension, the various cardiomyopathies that can manifest, and pulmonary arterial hypertension can also present with chest pain. The other important diseases, the aorta related diseases, the dreaded one is the aortic dissection. Though not a very common, but then you could have a catastrophic, because the patients would die immediately if you do not diagnose it immediately. So based on where the dissection has happened, whether it is in the descending aorta, arch, or ascending can dissect up to the pericardium, it can cause catastrophic death immediately and aortic regurgitation also. So the patient would come with sudden sharp pain. It would be because of the hematoma compression there. So based on the length of the dissection as well as the location of the dissection, the patient's features would vary. So asymmetry of pulses, there could have lower limb BP may be absent. Sometimes they may have quadriplegia that could come there. That is how you suspect it. So you have the classification, which is based on the Stanford's, where it occurs based on where the location of the dissection is. Important, the proximal the dissection, it can involve the coronary ostia resulting in MI. It can disrupt the aortic valve causing aortic regurgitation, and it can extend into the pericardium resulting in pericardial tamponade that you see there. Common causes of aortic dissections, trauma is the common cause. The non-traumatic causes are in connective tissue disorders like Marfan's, Ehlers-Danlos syndrome, osteogenesis imperfecta. Sometimes other connective tissue disorders. Pregnancy can also associated with aortic dissections that could happen. Other conditions of aorta are aortic aneurysms, where you could have the pain that could be seen there, and that's a other cause that you could see there. Coming on to the pulmonary causes, the important pulmonary causes, pneumothorax, pleural effusion, pleuritis, the pneumonia, and pulmonary embolism. So pulmonary embolism, again, you would have a risk factor that is there, either deep vein thrombosis that's happening in the legs or the pelvic veins. Sometimes de novo embolus can happen in the lung itself. So sudden, sharp, pain localized to one side, severe. Depending on how big is the embolus and what vessels have been blocked, the manifestations may occur. If it's a small vessel getting blocked, the patient may just have some pleuritic chest pain and nothing else, local lesion. If it's a big vessel, the major pulmonary vessel can get blocked, or a saddle embolus where both get blocked, patient can come with hemodynamic collapse. There could be tachycardia and the patient would succumb very rapidly. So it's important for us to understand what is the amount of embolism that's happened and how the patient's condition is. So based on that, we will have to manage the patients that could be seen. Pneumothorax, a primary spontaneous pneumothorax can happen in tall individuals, people with Marfan syndrome, people with emphysema, travel history, male, smoking, etc. And based on that, they will have a sudden onset of sharp shooting pain. And again, based on the amount of pneumothorax, the symptoms would be a mild pneumothorax only can have mild dyspnea, a tension pneumothorax can manifest with cardiovascular compromise that you could see there. Pleurisy could be occurring with the initial phases of the pleural effusion. So before the pleural effusion would set in, pneumonia can have a pleurisy. You may be able to auscultate a pleural rub, localized lesion. Bronchial asthma, reactive airway disease, cystic fibrosis, bronchiectasis can also have chest pain as a manifestation. The non-cardiopulmonary causes, coming on to the GIT causes. So you could have an esophageal, so you could have an esophagitis, could have a gastritis, gastroesophageal reflux disease, the peptic ulcer disease, important. So these patients would have a burning sensation possibly and associated with nausea, vomiting, and then the patients can have water brash sort of symptoms that could be seen. That's how you can diagnose. The other conditions in the GIT could be esophageal spasm, which again relieves. This is a very close mimic of MI because it also relieves with nitrates, retrosternal. Sometimes you could have something called as a Boerhaave syndrome or the Mallory-Weiss stare. Patient retches and then there is a full thickness stare or partial thickness. Submucosal injury could be Mallory-Weiss and a full thickness of the esophagus injury could cause Boerhaave syndrome. You could have gallbladder disease manifesting with the pain. It irritates the diaphragm and you can have a pain there. They could have other features that could be seen there. Sometimes pancreatitis also, which is rare, can manifest with chest pain as a manifestation that you could see. So you could have these features that could be seen there. Next, coming on to the musculoskeletal pain. So you could have the costochondritis, what we call it as the Tietz syndrome. The second and third intercostal spaces, they have tenderness there that could be pawned there. You could have the trauma, rib fractures can produce that pain there. Also, you could have the cervical radicular pain that can sometimes come there. Occasionally, you could have pain due to cervical ribs or the trauma to the ribs or the rib erosions like a Pancoast tumor can produce there. Sometimes the shoulder related pains can manifest or can come to the chest. Very important is intercostal nerves. Herpes zoster can come there or any intercostal neuralgias can manifest like that. The psychiatric or emotional causes are the other important causes for chest pain where the patient can have stresses and they can say that they are feeling a chest pain, which may not be very specific in diagnosis. So whenever a patient comes with chest pain, we have to obviously rule out the potential life-threatening, that is your acute coronary syndrome, acute pulmonary embolism, a pneumothorax, aortic dissection, and sometimes maybe a esophageal rupture. So these are the important ones that we have to look into, keep in mind, and the rest of them can maybe we can manage a little slowly. So it depends upon the patient's stability. So we have to stabilize the patient first, do quick investigations to localize each of these diseases and then proceed to management. Very importantly, we will have to ask for histories, quick histories has to be taken, and we have to stabilize the patient quickly. ECG is mandated, urgent chest X-ray is mandated, sometimes echo and the cardiac enzymes and BNP can also be done. So these would help us to localize or differentiate each of these diseases that are presenting that is there. So as we said, the history is important. The history forms the cornerstone. If a patient has diabetes, hypertension, and then chronic stable angina, none comes with severe chest pain, we know that it's possibly acute coronary. Patient with emphysema comes with sudden onset severe breathlessness. It could be a pneumothorax that could be seen there. So it's very important that the history will give us the clue. Past history of fever, pleurisy, you could get a pleuritic pain there. Sometimes the patient who is a tall statured and the patient says that there is like a knife cutting from the center, it could be aortic dissection. So history is very important, which gives us a clue to majority of the diseases that we could find out based on the history. And past medical histories, if the patient is on certain drugs, NSAID is taking, or the patient is on oral steroid, then we know it could be a peptic ulcer disease. So we can get a clue into that. Or based on the drugs the patient is taking, then we can make out whether the patient has a risk factor for a coronary artery disease or not. So our description of the pain and other features will help us to take a diagnosis, to make a really differential diagnosis persistently, whether it's a cardiac or a respiratory or a GI cause. That's the three basic things. And also whether this patient is actually emergent or a non-emergent etiology that we're looking at. One important feature is you will have to understand that fever, if a patient comes, yes, it's an infective cause that it be, maybe a pleural infection or maybe a pneumonia coming there. But also remember, MI also manifests with fever. So myocardial infarction also has a fever as a manifestation that could be seen there. The pain which is not classical of angina, just a substernal vague chest discomfort, could be MI. So not all the patients would fit into your classical description. So we will have to definitely investigate a patient based on the feature that could be seen there. Sometimes you may get clues in the history, provoked features. So supposedly a patient has gone on an exertion in a cold weather and come back, that could be more suggestive of angina. If a patient has had alcohol and there is vomiting and retching, then we know it's a Malrivi stare that's there. Or an alcoholic patient who was found unconscious and now the patient is severe chest pain, is complaining, could be a pleurisy, could be a pneumothorax trauma. The drug histories also will help us. Nitrates relieving mostly MI, angina, but nitrates also relieve esophageal spasm. So that is what we'll have to think of, whether the patients have relief with nitrates or not. Associated symptoms, if it's an MI, it has perspiration, dyspnea, sense of doom there, that could be there, vomiting that could be there. If the patient has hematemesis and then there is a gastroesophageal reflux symptoms, water brash that's there, we are looking at that. If there is a hemoptysis, then we know it's a pulmonary embolism. If the patient has a dry cough and a lateral chest pain and dyspnea, it could be a pleural effusion. History of leg swelling in the past and now comes with the dyspnea and chest discomfort, it could be a pulmonary embolism that we are looking at. So associated symptoms also help us. A quick examination is mandated. So you will have to check for the patient stable. The vitals have to be measured. Patient has hemodynamic compromise. The BP is low. It could be an acute inferior wall MI or it could be a tension pneumothorax. Look at the neck veins. Look at the pulses. Check for the saturation. Look at the oral mucosa, cyanosis if it is present. Auscultate the lungs. Crepitations is there, or look for if there is breath sounds are absent, that's there, or you might get an S3 or a gallop or an acute MR. So all these features would help you to localize the particular disease that we are looking at. Abdominal tenderness could feel a GARD or a pancreatitis or a peptic ulcer disease. Lower limb pulses are absent, it's possibly an aortic dissection that's there. All these features could help us in the diagnosis of a acute condition that you could see there. It's important for us to do certain immediate investigations, as we said. The ECG is first thing that we look for. So ECG can help us to diagnose a few of them. MI definitely it can show us. Pericarditis it can show us. You might get pulmonary embolism, the classical sinus tachycardia, RV strain, RBBB, S1Q233 function may be there. You can use certain of that. A chest X-ray definitely will tell us. It can show us pulmonary edema, pneumothorax, pleurisy. sometimes aortic dissection also. Urgent echo can help us in diagnosing quite a lot of this, maybe regional wall motion, pericarditis. You can do the ultrasounds for pleural effusion as well as the abdominal findings can be seen there. So all of them will help us in that you could see there. So our basic clinical approach would be to urgently devise the approach and make out whether we have the life-threatening causes which have to be ruled out, and based on that we go on to management of the patient that is seen. So the cardiac is the main thing that we have to rule out. So the ECG, the cardiac enzymes are paramount. Even the BNP can be done emergently, which can help us to identify the possible cause of chest pain that the patient has come in. Sometimes the patient's ECG may be not showing the characteristic features, the cardiac enzymes may not be elevated. In such conditions, possibly we will have to repeat the cardiac enzymes after 2 to 3 hours, and possibly we may have to also do some other imaging modalities to rule in if it's a cardiac, maybe a CT angio or a traditional angio, especially for your aortic dissection is needed, we have to do it. For a pulmonary embolism, we have to do a CT pulmonary angiography or a ventilation perfusion scan. Such things may be needed, especially in an acute care for diagnosis as well as the management. Later, once the patient is a little stabilized, we can do the other investigations and find out particular type of the disease and localize what is the cause, etc. But our diagnosis basically is to manage it acutely, so we would want to know what is the cause that could be seen there. So various algorithms are available, clinically as well as evaluation, investigation, echo, ECG wise, to rule in or rule out a acute coronary syndrome, and quite a lot of AI based techniques are available now for the emergency diagnosis of these important causes of life-threatening chest pain that is there. So it's very important for us to identify it, segregate it and manage it. For all the rest non-life-threatening causes of chest pain, we can slowly evaluate and possibly find the diagnosis of that. Student, in today's session we discussed the approach to chest discomfort, the variety of causes, the specific features, the differentiating features, and how do we arrive at a diagnosis and make the diagnosis of life-threatening conditions which can manifest with chest pain and the other causes. Hope this session was clear. Thank you.